Good evening, everyone. Thank you for joining us once again for our monthly Friday webinar series. Today's webinar is on COVID-19, mitigation, treatment, and vaccines. And my name is Brett Spatel. I'm the Vice President of Advancement here at the National Hemophilia Foundation. I'd like to introduce our speaker today, Dr. Phillip Jacobson. Dr. Jacobson graduated from the University of Illinois Medical College. He completed his residency in pediatrics at the combined program of Phoenix Children's Hospital and Maricopa Medical Center in Phoenix, Arizona. Thereafter, he trained further in a fellowship program in pediatric critical care at the University of Washington in Seattle. Upon completing his fellowship he became an attending physician and a charter member of the Rush Cook County Pediatric Critical Care Program. He has served as a pediatric critical care attending physician for over 27 years. Dr. Jacobson is now the Senior Medical Director of Base 10 Genetics, a company providing COVID testing and tracking for a variety of corporations and long-term care facilities. Dr. Jacobson is an Associate Professor of Pediatric at Rush University and has worked extensively with respiratory viral infections and mass casualty situations. We thank you for being here, sir, and now I'll turn it over to you.
Thank you, Brett. I want to get straight to the content because we have a lot to talk about. Many of you are familiar with this picture of the SARS-CoV-2 virus, the virus that causes the COVID-19 disease. And it's got these distinctive red spikes on the outside. If you look at a coronavirus on an electron microscope, it has the appearance of these spikes looking like a crown surrounding the virus, hence the name coronavirus. There are many coronaviruses, many of them infect humans. Most of them cause just simple common colds. This one happens to be very lethal and is responsible for our current pandemic. In the immediate family of this virus is the original SARS virus, which caused a lethal pandemic several years ago. Next slide, please. I want to show you a little more detail about what this virus looks like and explain a little bit more about how it acts. These red spikes correspond to the red spikes you saw on the previous slide. These red spikes represent what we call the spike protein or the S protein. This spike protein is responsible for the virus attaching to a human cell. It will also be very important in the production of vaccines that we'll talk about a little later. The yellow beady looking like structure in the center represents the RNA, the genetic material of the virus responsible for its replication and protein production. Next slide, please. Now, as the virus enters the cell, usually by inhalation, and the first cells that it will encounter are those of the respiratory tract. And when the virus attaches to a cell of the respiratory tract, it unleashes its genetic material into the cell. The genetic material, the RNA, then uses the apparatus of the cell and the number of the elements within the cell to reproduce and produce more copies of the virus. After many copies of the virus are produced, the cell is killed, the virus is released and prepared to infect other cells. Next slide, please. Now, the body can't just let this virus go and kill its cells and replicate and do its thing. So it has to mount a response. And the body will mount an immune response which will cause lots of inflammation, especially if if the immune system had never seen this virus. And when it mounts this immune response causing all this inflammation, it's kind of a generalized immune response, a generalized inflammation. And this inflammation can actually cause more damage and diminish lung function even further. Not only that, but the inflammation is caused by lots of chemical mediators, what we call cytokines or white blood cells. And these things don't just stay in the lungs, but they actually go and circulate around the body, and they could cause problems throughout the body in addition to the lungs. Next slide, please. And you'll notice the inflammatory process as all these mediators and white cells travel around, they could affect and cause problems for many different organs of the body. Not only that, but there seems to be a predilection for clotting, for blood clotting with this virus. So in addition to the inflammation, the virus itself, and now you have blood clotting causing diminished blood supply to these organs, you have a big problem in a disease called COVID-19. Next slide, please. So this generalized inflammatory process that I was talking about is otherwise known as the innate immune system. The innate immune system, or innate immunity, is what kicks in when the immune system hasn't yet seen this particular pathogen or virus. And what ends up happening, you get a non-specific response. There's no specific antibodies or specific cells that target this pathogen directly. It's just a more profound inflammatory response. It's like taking a sledgehammer to kill a fly, but you end up breaking the window. Now, the adaptive immunity kicks in after the body is familiar with this pathogen. It's seen it before. And then when the adaptive immunity kicks in, you get a specific response. You get antibodies, you get specific T cells, you get elements that are like a precision guided missile to target the pathogen and leave the body alone. So the pathogen is processed quietly, and it either protects you from any disease or you get very mild disease associated with it. During the production of vaccines, the whole idea is to try to get the immune system, to switch the immune system over to the adaptive immunity so that the immune system has the recognition to be able to process the pathogen quietly and protect the person from disease. Next slide, please. Now we'll go on to the different signs and symptoms if someone does get infected with COVID and does have symptoms. Anybody who's walked into a dentist's office or a doctor's office has to take a health survey, and they ask all these questions. Do you have fever? Do you have cough? Do you have shortness of breath? Fatigue, muscle aches, headache, diarrhea, nausea or vomiting, sore throat, congestion, runny nose. All of these things are symptoms that could be associated with COVID-19 disease. Interestingly enough, how does this differentiate the virus from other common respiratory viruses like the flu? Really doesn't. But because this virus is so widespread right now that any of these symptoms should be considered as if it's very possible that the person has an infection with SARS-CoV-2. Now, I want to call your attention to the one on top right, the loss of taste or smell. This seems to be particularly a unique symptom of the SARS-CoV-2 virus. And somebody with this symptom, it's much more likely that they have the virus than even the other symptoms. Next slide, please. Now, what if someone's sick enough to see the doctor or have to go to the hospital? They're going to do some blood tests. And so I want to just go through some of the abnormal blood tests that might be found in a COVID-19 disease. When you get cell counts, CBC, you might be familiar with, you're going to have different kinds of white blood cells that you'll note on a CBC test. And usually in a respiratory virus, you'll see an elevated lymphocyte count and lower neutrophil count. For some reason, it's the opposite with this particular virus. There's a higher neutrophil count and a lower lymphocyte count. The next test you see on there is erythrocyte sedimentation rate, otherwise known as ESR, and the C-reactive protein. These blood tests are general markers of inflammation, and you see they're elevated because the profound inflammatory response associated with the disease. If you look down in the middle where it says liver enzymes, the liver tends to get inflamed and sick during this disease, so you'd see elevated liver enzymes. And down in the cardiac section, the heart gets damaged and the heart gets inflamed, and some of these blood tests are associated with heart damage. I mentioned before there's a predilection towards clotting with this particular disease, and you see an elevated D-dimer and prothrombin time associated with someone who's going through a lot of clotting. I should point out that for people with bleeding disorder, even without the infection, they're going to have abnormalities in these lab tests. So these lab tests are probably not useful in a COVID-19 disease in someone with a bleeding disorder. Next slide. If the disease progresses to life-threatening manifestations, there would be respiratory failure, shock, stroke, blood clots in various parts of the body, damaging the organs, and possibly death. Now, all these life-threatening manifestations are due to the inflammatory response, the clotting, and the virus itself. Next slide, please. So how do we treat severe COVID disease? Well, most people who have severe COVID disease have a lung involvement and diminished oxygenation. So supplemental oxygen is really a mainstay of treating this disease. Next on the list is anticoagulation. Anybody who's hospitalized, who's relatively immobile today, most people are treated with some kind of anticoagulation to prevent blood clots associated with this immobility. This is even more important for patients hospitalized with COVID-19 disease because of this predilection to clotting. Now, this gets complicated for people with bleeding disorders. How do you go about handling this? Well, a lot of places will give factor first and then start using anticoagulations. I think it's a must for patients with bleeding disorders and COVID-19 disease in the hospital that they get a hematology consult to help guide this anticoagulation therapy. It's even very common for patients without bleeding disorders who are hospitalized with COVID-19 disease to have hematologists as part of the team to help guide this therapy. Going down to antiviral, there is a medication called remdesivir made by the Gilead company. Now, remdesivir is a nucleoside analog. What that means is it's a molecule that's structurally similar to one of the building blocks of the genetic material that the virus uses to replicate. It looks like a building block that the virus uses. So when the virus is replicating, it may take a molecule of remdesivir instead of one of the nucleosides it's supposed to put in certain spots, thereby disrupting the viral replication and ultimately causing killing of the virus. And this particular drug does have EUA status, and it's been shown to lessen the severity of illness. Another therapy is monoclonal antibodies. I mentioned before how nice antibodies would be for this precision-guided missile type of therapy, would attack the virus directly. So why can't we just get hold of these antibodies, put them in a bottle, and administer them to the patients? Well, in fact, this is what's been done. There are two companies with EUA authorization for their products. They are from Regeneron and Eli Lilly. And each of these companies created a cocktail of what I'm calling specific antibodies, monoclonal antibodies that target areas on the virus. And when these agents are administered via IV, and so in other words, instead of waiting for the immune system to kick in, a person who doesn't have these antibodies, you give it to them. This is called passive immunity as opposed to active immunity when you deliver an immunization, which will ultimately have the body produce its own antibodies. This particular product just is something, just give the antibody directly to the patient. The Regeneron company, and these products also have been shown to lessen the severity of illness, and so they've been very helpful. There is a product that Regeneron is right now testing that they created where they would attach these antibodies to adeno-associated virus and deliver them via inhalation the same way in which the virus infects the body. And there's more about this that we'll see later over the course of the next couple of months. I should point out that both the antiviral and the monoclonal antibody therapy strategies are very good, but they're not so useful once the disease gets really severe and the inflammation is so profound that just killing or stopping the virus itself isn't enough. And so it's important to try to use these therapies earlier in the course of disease rather than later. And lastly, I want to talk about immunomodulation. I have been emphasizing the idea that inflammation, this terrible inflammatory response, is part of the severity of the disease. So why can't we give something to suppress the immune system and maybe make people better? And This concept was contemplated early in the pandemic by the medical community, but physicians were worried. What would happen if we suppressed the immune system and then the virus ran amok and it killed more people? But ultimately, trials were done mostly with dexamethasone, a powerful steroid, to suppress the immune system. And sure enough, steroids have been shown to save lives, reduce the severity of illness, and really be helpful for patients with severe COVID disease. Next slide. Despite all the advancements in therapy for the severe disease, prevention is still the best thing we have. Everybody's seen all of these strategies, can't be emphasized enough. Masks are important to wear, social and physical distancing, hand washing, or using at least 70% alcohol sanitizer, isolation of people with or suspected to have COVID-19, isolating people with exposure to people with COVID-19. All these things really do work. Next slide, please. I want to talk a little bit about masks. What's a good mask? A good mask is one that has 2 or more layers of washable, breathable fabric. So it has 2 layers for protection, and it's also comfortable enough to wear. You don't want something that's so comfortable that people are trying to rip it off all the time. The mask should completely cover the nose and mouth. Sometimes you see people having the mask just cover the mouth and not the nose. That's not adequate. The mask should fit snugly against the sides of the face and not have any gaps. I want to call your attention to the right column middle right now. You might see a lot of masks with these valves on them. And what this does is that it protects the person wearing the mask, but the valve allows exhalation and doesn't really filter out these droplets where the virus resides. And so somebody who's infected with the virus breathing out could be infecting others. Next slide, please. And then, of course, social distancing, maintaining a good distance apart, wearing masks as much as you can. When you're outside, if you're not wearing a mask, you still got to stay at least 6 feet apart to prevent transmission of the disease. Next slide, please. I want to talk about vaccines. And what I'm going to do is I'm going to talk about the general principles of what makes a good vaccine. And then we'll talk about 4 candidates of that COVID-19 vaccines that are either already authorized or on the horizon. Next slide, please. What makes a good vaccine? Well, the first thing is immunogenicity. Any vaccine you administer to somebody should elicit an immune response. That's what we're trying to do here. And then safety. There are several layers to safety. The first one is at the time of injection. So the vaccine shouldn't cause a disease that it's designed to prevent. The vaccine shouldn't cause an immediate life-threatening reaction. You may have heard about during the first couple of days when they were administering the Pfizer vaccine in the UK, that 2 people had a severe allergic reaction. And we'll get into that a little later in the discussion. The vaccine should stimulate production of neutralizing antibodies. What do we mean by that? Not all antibodies are created equal. Neutralizing antibodies are essential. What are neutralizing antibodies? Neutralizing antibodies are antibodies that can neutralize the virus in one of 3 different ways. One is they can prevent viral attachment to the human cell. Another way is they might prevent fusion of the virus with the human cell. And the third way is to prevent release of the genetic material into the human cell. So a neutralizing antibody that does any one of these 3 things is a neutralizing antibody. And this is very important for protection. Then we talk about the adaptive immune response. This is what we're trying to achieve. The adaptive immune response should be protective, though, and not harmful. After developing adaptive immunity, subsequent exposure to the pathogen should be protective and not harmful. And I have down there Th1 versus Th2, which I'm going to discuss on the next slide. This is a little bit complicated, but it's so important that I want to go through this with you. As you know, white cells are designed to protect us from pathogens. And there are many different kinds of white blood cells. And one kind is the T helper cell, abbreviated TH. This is also known as the CD4 cell. The T helper cells are essential in adaptive immunity because they orchestrate the type of immune response that occurs. And so they decide what kind of antibodies are released, what kind of white blood cells, what kind of chemical mediators, cytokines, etc. And there are two different kinds of TH cells, TH1 and TH2. TH1 cells, they tend to orchestrate a quieter immune response and processing of the pathogen. And this is desirable. We want a TH1 predominant response from our vaccines so that it could be protective. TH2 response, especially for respiratory viruses, upon re-exposure to the virus after the vaccine, can cause severe allergy asthma type of reaction and could even be worse than the disease itself. So TH1 predominant immune profile is essential in a vaccine. Next slide, please. Another layer of protection is that weeks after the vaccine, what we don't want to see is an autoimmune effect or some other type of side effect from the vaccine that's delayed that would cause harm. And for the COVID-19 vaccines, the FDA was very strict about waiting till the last, in the clinical trials, they were waiting for 2 months after the last injection was done to ensure that this didn't happen. So even though the pandemic is raging and there was some political pressure to get this thing out as quickly as possible, they were responsible enough to wait to see what kind of post-vaccination reactions would occur. And finally, vaccines should elicit a long-lasting immunity. Next slide, please. Now I want to talk about the specific COVID vaccines that are either here or imminently coming on arrival. Next slide. I showed you this picture of the virus before with the details of what it looks like. And I call your attention once again to the red spikes on the outside, the spike protein or the S protein. This protein is responsible for viral attachment to the human cell, but it's also highly immunogenic. It stimulates the immune response to produce really good antibodies that neutralize the S protein and thereby neutralizing the virus. And it stands to reason that this protein would stimulate that kind of response, because if this protein is responsible for viral attachment to the cell and the antibody attaches at the point of where it connects with the cell, then it could block the cell from attaching, it could block the virus from attaching to the human cell. Next slide, please. Now, there are over 200 candidates of vaccines in various stages of development. 11 candidates in there are 11 candidates in phase 3 trials. News is moving so quickly that this slide is already outdated. I said here 4 candidates are getting close to being awarded EUA status. 1 candidate already got EUA status over the weekend, the Pfizer vaccine. 3 others are very close. And this 1 candidate that is shown on the bottom is the Pfizer vaccine, authorized in the UK, Canada, and the United States. The first injection was administered outside of a clinical trial on Tuesday, December 8th. Next slide, please. The 4 companies, by the way, before I go into this, are Pfizer, a teaming of Pfizer and BioNTech. Another one is Moderna. Another one is a team of Oxford University and AstraZeneca. And another one is Johnson & Johnson. These 4 entities have created the vaccines that are either already got EUA status, the Pfizer one, and the 3 others are probably going to get EUA status very shortly. EUA status meaning emergency use authorization. This is the sort of fast track approach to getting a product that's essential on the market during a situation like this, short of FDA approval. So 2 of the vaccines are mRNA vaccines, genetic vaccines. And these are the Pfizer vaccine, the one that just got authorized, and the Moderna vaccine. And I want to take you through what an mRNA vaccine is, especially for COVID-19. The mRNA from the virus coding for the S protein is isolated. Then it's packaged in a certain lipid nanoparticle in a certain way. It's then injected into the human, where the mRNA enters the human cell. The mRNA then uses the cell to produce S protein. S protein is then released from the cell into the blood, where it meets the immune system. The immune system then begins the course of recognition and stimulates the memory process of adaptive immunity for the next exposure. So the human cell is producing the S protein, which ultimately serves as the antigen for the immune system to attack. Next slide, please. Now, a lot of people come up to me and say, and even healthcare personnel, and they say, I'm worried about this genetic vaccine. I don't want it altering my chromosomes. I don't want to get cancer. I don't want to have infertility, all kinds of things that they think about. So I want to take this slide to review a little bit of high school biology, cell biology, to explain what this is. If you look at the blue area, and inside the blue, that's the nucleus of a cell. Inside the nucleus, that's where the human chromosome resides. If you look at the yellow area, that's called the endoplasmic reticulum. The endoplasmic reticulum is in the cytoplasm. The mRNA goes to the endoplasmic reticulum, where it guides the production of the S protein. It does not enter the nucleus, and it does not alter the human chromosome. Next slide, please. Now, Pfizer and Moderna report, these are the mRNA vaccines, 95% efficacy in phase 3 trials, which is really quite good. The Moderna tested 30,000 people. Pfizer tested 44,000 people. In the Moderna trial, 11 of the people who received placebo that got exposed to the virus developed severe disease. There were no subjects who actually received the vaccine that developed severe disease. Very good news. Next slide, please. Both vaccines stimulated large neutralizing antibody production. I mentioned how important that was. Both vaccines stimulated a predominantly Th1 protective immune profile and not the Th2 kind. There were side effects: fever, headache, myalgia, chills, pain in the injection site, which is more common after the second dose. And a lot of people say, well, this is good news because all of these symptoms let you know that the immune system is kicking in and it's responding to the injection. No post-vaccination deleterious effects occurred 2 months after the second dose for either one of these vaccines. Next slide. I'd like to point out before I mention this that for the Pfizer vaccine, when the FDA advisory panel was reviewing it, I read in an article that Eric Rubin, who's the editor-in-chief of the New England Journal of Medicine, a Harvard microbiologist, and a member of this panel, was quoted as saying that this vaccine, the efficacy is overwhelming, quote unquote. Now, what about, there are issues with this vaccine: storage and transport. The Moderna vaccine requires storage at -20 degrees. The Pfizer vaccine requires storage at -70 degrees. And this is a logistical issue that is being worked on. Next question is, how long will the protection last? We really don't know because we didn't have time to wait on these clinical trials and follow the subjects over a couple of years to determine how long their immunity would last. The pandemic is just too severe and people need this vaccine now. Also, for both of these vaccines, 2 doses are required. And lastly, for the Pfizer vaccine, an allergic reaction occurred, and 2 severe allergic reactions occurred for 2 people, and we'll address that issue in the next slide. So 2 people in the UK who got the Pfizer vaccine had history of allergies beforehand, and when they got the vaccine, they developed severe reactions shortly after the vaccine was administered. I should point out that both of these people, healthcare workers, as a matter of fact, they had severe allergic reactions in the past, so much so that they had to carry um, EpiPens with them. So there's not just a little seasonal hay fever, but real severe reactions. The UK is now recommending that people with history of severe allergic reactions refrain from getting this particular vaccine. I like to point out that 1 out of every 1.4 million people have allergic reactions to vaccines of any kind. Now, this is rare, but it's still not unheard of. We are familiar with this and we've treated it. Healthcare workers who administer the Pfizer vaccine may have to be prepared to treat allergic reactions. Next slide, please. I want to talk now about viral vector vaccines. The other two candidates that I mentioned, the one from Oxford AstraZeneca team and the one from Johnson & Johnson, are what we call viral vector vaccines. And I want to take you through what a viral vector vaccine is. With recombinant genetic technology, a segment of mRNA coding again for the S protein is attached to a virus, an adenovirus. The virus combined with this piece of mRNA is injected into the human, and the mRNA that codes for the S protein is delivered into the cell. The cell then makes copies of the S protein from the code. The S protein is then released from the cell into the blood where it meets the immune system. The immune system then begins the course of recognition and stimulates the memory process of adaptive immunity for the next exposure. This sounds familiar. There is a similarity between the viral vector vaccines and the mRNA vaccines. Both of them deliver mRNA coding for the S protein to the cell so that the cell produces the S protein, which ultimately serves as the antigen for the immune system. The difference is how the mRNA is delivered. The mRNA vaccines are packaged in these little lipid nanoparticles, and the viral vector vaccines, the mRNA piggybacks off of viruses into the human cell. Next slide, please. So I want to compare these two viral vector vaccines. Oxford AstraZeneca uses a chimpanzee adenovirus as its viral vector. And they went through phase 3 trials, and very puzzling, but very promising. They had over 70% efficacy, but interestingly enough, their lower dose seemed to be more efficacious than their higher dose vaccine. Now, they had some issues conducting their phase 3 trial. They started in the UK when the pandemic was raging, and then when the UK got more control of the virus, the company had to move the trial to a place where there was still a lot of transmission, high positivity rate. So they had to move from the UK to Brazil, changed hemispheres, and even changed placebo. In the UK, they were using meningococcal vaccine. In the Brazil, they were using saline. So many changes took place with this trial that it was puzzling. Still good data. Now 30,000 people or more subjects are being tested in the US, where there's a lot of disease, a lot of virus, and preliminary results are very promising. Johnson & Johnson vaccine uses human adenovirus AD26. A lot of human adenoviruses are really pathogenic. This one's very weak, but it's effective in delivering the mRNA to the cells. Very promising phase 3 trials, 60,000 subjects. One advantage of the viral vector vaccines is that it's not so temperature sensitive like the mRNA vaccines. So logistics of transporting and storing aren't as bad, and it'll be easier. A nice aspect of the Johnson & Johnson vaccine is that it appears, not 100% sure, but it appears that 1 dose will be necessary, not 2. The other 3 will require 2. Next slide, please. So what about using live viral vector vaccines for people with bleeding disorders? Well, we should point out that patients with bleeding disorders are not inherently immunocompromised, and they should be able to receive a viral vector vaccine without fear of disease from an adenovirus. These 2 viral vectors are adenoviruses. Possible exceptions may be patients who are on steroids, patients with HIV with a low CD4 count. These patients, both of these types of patients, are immunocompromised, and it's not a good idea to administer any kind of live virus to patients who are immunocompromised. Now, remember, for all four vaccines that I'm talking about are delivered via intramuscular route. Therefore, it's probably wise to have some factor to prevent bleeding before getting injected, and then pressure should be applied 10 minutes afterward at the injection site to prevent hematoma or bleeding. Next slide, please. I mentioned 4 different viruses in this discussion, and I want to put them side by side to avoid any confusion. The chimpanzee adenovirus is the viral vector for the AstraZeneca vaccine. Coronavirus, SARS-CoV-2, is what's responsible for the current pandemic. Human adenovirus AD26 is the viral vector for the Johnson & Johnson vaccine. And I mentioned before that the company Regeneron had an antibody therapy that they were using for inhalation. Well, the viral vector used to deliver the antibody is called adeno-associated virus. And what's important about this is that if you have a product that has adeno-associated virus associated with it, it does not preclude you from receiving a product with adenovirus. These are 2 different things, adeno-associated virus and adenovirus. Having something with adeno-associated virus will not cause inactivation of something with adenovirus in it. Next slide, please. There are a few important facts about vaccine. The vaccine will protect people from COVID-19 disease, but it may not protect people from becoming infected with the virus itself. People who become infected post-vaccination will likely be asymptomatic or very mildly symptomatic. However, they may be able to transmit the virus to others. The data on this topic hasn't been fully worked out. What we do know is that it protects people from getting disease. Next slide. The advisory committee for the CDC on immunizations convened and wanted to, what they did was they decided on a prioritization schedule for who's in front of the line to receive the vaccines. And the first groups that are receiving vaccine right now are healthcare personnel and residents of long-term care facilities. Healthcare personnel get frequent exposures to people with disease, and so they're at risk. Not only that, but you need healthcare personnel to be well enough to take care of patients with COVID-19 disease. Long-term care facilities are extremely vulnerable. The patients of long-term care facilities are extremely vulnerable. There are 3 million residents in long-term care facilities, and they account for 40% of the deaths associated with this virus. So that's why these 2 are the first to get vaccinated. Next slide. The next groups under consideration, and not necessarily in order, teachers, firefighters, police officers, essential workers, elderly, and people with underlying conditions. And this is still being worked out. I'd like to stop there and just wish everybody safety from this virus and everything else. And please strongly consider receiving one of these vaccines, consult with your physician, and I'll stop there.
Thank you so much, Phil, for joining us. We truly appreciate you taking your time and sharing your expertise with us. We'll stop there as well, too. And we truly thank you for being with us. Thanks, Phil.